Good afternoon, everyone. My name is David Patrician. I'm one of the third-year psychiatry residents here at the Saskatoon site. I apologize for not having met many of you. Usually I make an effort to meet each of the medical students on rotation at least once, but I've been working on geriatric psychiatry over at City Hospital for the past little while. Today we're going to be talking about anxiety and related disorders. The primary reference for this presentation is DSM-5 Treatment Revised Edition, and the Canadian Mood and Anxiety Task Force Guidelines on Anxiety and Related Disorders. These are the objectives for today's presentation. As we'll see, I've prioritized 4 elements of each disorder we will discuss. I don't expect you to recall the entirety of the DSM-5 criteria at your current level of training, nor do I think it would be very good use of your time. I tried to make this presentation as high yield as possible, and in doing so we'll focus instead on the essential features of these diagnoses. But if you feel especially keen, these slides, which I will provide to you after the presentation, include the detailed DSM-5 criteria. After participating in this presentation, you should be able to recall the essential features of anxiety and related disorders, recall their prevalence and risk factors, construct a 3 to 4 item differential diagnosis for patients presenting with chief concern of anxiety, and name some of the common treatments used to manage these disorders. For each disorder we speak about today, the following framework will be applied. First, we'll review a case vignette, which will set the stage for the other 4 elements, which are the essential feature, epidemiology, differential diagnosis, and treatment. I highly encourage audience participation and will solicit it as needed. Of course, because this is a pre-recorded PowerPoint presentation, I will allow time after asking each question so that you are able to think of an answer before moving on to the next slide. Alright, so let's start with case 1. Dave is a 28-year-old male college student with no previous connection to psychiatry. He reports struggling with always feeling worried, which has been a lifelong struggle, but worsened in his teenage years as he transitioned from high school to university. He reports feeling restless and tense, particularly when stressed with final exams, and experiences initial insomnia more days than not due to not being able to shut my mind off. Concentration has been an ongoing concern as well, and he tells you it's been particularly difficult to put together a PowerPoint for his classmates. ADHD scales do not support that diagnosis. What is the most likely diagnosis in this case? If you guessed generalized anxiety disorder, you're correct. The essential feature of GAD is excessive anxiety and worry about a number of events or activities which last for at least 6 months. The mnemonic I use to recall the diagnostic criteria for GAD is Macbeth frets constantly regarding illicit sins. This stands for muscle tension, fatigue, concentration problems, restlessness, irritability, and sleep problems. 3 of these are required for diagnosis. With the diagnostic criteria in mind, let's return to the case of Dave. Here, Dave reports always feeling worried, especially during life transitions. He reports feelings of restlessness, tension, sleep problems, and poor concentration, which has been a lifelong problem. Therefore, he meets criteria for generalized anxiety disorder. Now let's talk about epidemiology. Can someone tell me how prevalent generalized anxiety disorder is? What are some of the common risk factors for generalized anxiety disorder? As you may recall from statistics, prevalence refers to the proportion of persons who have a condition at or during a particular time period, whereas incidence refers to the proportion or rate of people who develop a condition during a particular time period. Here the 12-month prevalence of generalized anxiety disorder in adolescents is 1%. This means that in any given 12-month period, 1% of adolescents have GAD. In adults, this increases to 3%. And if we examine patients at all stages of life, prevalence increases further to 6%. Females are twice as likely to develop GAD compared to males, and the median age of onset is 30. As you may know, risk factors for mental health conditions are divided into three categories. That is genetic and physiological, temperamental, and environmental. Here and throughout the rest of the presentation, risk factors in green refer to genetics and physiology, blue refers to temperamental characteristics, and red refers to environmental exposures. Here we see increased risk for GAD in patients of European descent, as well as a high proportion of risk determined by genetics. That is, as much as 1/3. Temperamentally, behavioral inhibition, neuroticism, and heart avoidance seem to predispose individuals to this disorder. And exposure to adverse childhood events and parental overprotection also increase risk. Now that we've identified his problem and understand its epidemiology, what disorders should we include in our differential diagnosis for this condition? There are at least 6. I would ask that you would be able to name a couple, and as you do so, can you justify your response? Why would you include them in the differential diagnosis of generalized anxiety disorder? This is the differential diagnosis for generalized anxiety disorder from DSM. We'll examine each one of these in turn. There are many medical conditions which can produce symptoms of anxiety. As a general rule, these medical conditions result in increased outflow from the sympathetic nervous system. Examples include things like pheochromocytoma, pulmonary embolism, COPD, and seizures. The diagnosis of anxiety due to another medical condition is assigned if the patient's anxiety and worry are judged based on history, laboratory findings, or physical exam to be a physiological effect of another specific medical condition. Similarly, there are many different substances which result in symptoms of anxiety. These include things like caffeine intoxication, withdrawal from hypnotics, including alcohol, and exposure to carbon monoxide. A substance or medication-induced anxiety disorder is distinguished from GAD by the fact that a substance or medication, that is a drug of abuse or exposure to a toxin, is judged to be etiologically related to the anxiety. For example, severe anxiety that occurs only in the context of heavy coffee consumption will be diagnosed as caffeine-induced anxiety disorder. So how do we differentiate between OCD and generalized anxiety disorder? Several features distinguish the excessive worry of generalized anxiety disorder from the obsessional thoughts of OCD. In generalized anxiety disorder, the focus of the worry is about forthcoming problems, and it is the excessiveness of the worry about future events that is abnormal. In OCD, the obsessions are inappropriate ideas that take the form of intrusive and unwanted thoughts, urges, or images. How do we differentiate between PTSD and generalized anxiety disorder? Anxiety is invariably present in PTSD. Generalized anxiety disorder is not diagnosed if the anxiety and worry are better explained by symptoms of PTSD. Although anxiety may manifest in adjustment disorder, this residual category should be used only when the criteria are not met for any other mental disorder, including GAD. Moreover, in adjustment disorders, the anxiety occurs in response to an identifiable stressor within 3 months of the onset of the stressor, and does not persist for more than 6 months after the termination of the stressor or its consequences. So how do we differentiate between panic disorder and generalized anxiety disorder? Panic attacks that are triggered by worry in generalized anxiety disorder would not qualify for panic disorder. However, if the individual experiences unexpected panic attacks, as well as shows persistent concern and worry or behavioral change because of the attacks, then an additional diagnosis of panic disorder should be considered. So how do we differentiate between social anxiety disorder and generalized anxiety disorder? Individuals with social anxiety disorder often have anticipatory anxiety that is focused on upcoming social situations in which they must perform or be evaluated by others. whereas individuals with GAD worry whether or not they are being evaluated. In addition to these diagnoses, normal reactionary anxiety can also be considered in the differential. A little bit of anxiety is bound to be experienced when we are faced with a life challenge like a big exam or a date with a new partner. In these cases, generalized anxiety disorder should not be diagnosed because it is so transient and not typically associated with other symptoms. Now let's round things out by considering the management of GAD. I'm sure that everyone has heard of the biopsychosocial model for treatment. What would you recommend for treatment of Dave in this case? There are 7 different first-line medications for treatment of generalized anxiety disorder. They are duloxetine, which is an SNRI, venlafaxine, which is an SNRI, escitalopram, which is an SSRI, sertraline, which is an SSRI, paroxetine, which is an SSRI, agomelatine, which is a melatonin 1 and 2 agonist and an antagonist of the 5-HT2C receptor, and pregabalin, which binds the alpha-2 delta subunit of voltage-gated calcium channels. The mnemonic to remember these medications is Dave's PowerPoint. In psychiatry, we often use pharmacotherapy, but we also use psychotherapy to treat generalized anxiety disorder. What type of psychotherapy do we normally use? According to the Canadian Network for Mood and Anxiety Treatments, abbreviated CANMAT, CBT is an effective first-line option for generalized anxiety disorder. However, evidence does not support the routine combination of CBT with pharmacotherapy. But when patients do not benefit from CBT, a trial of pharmacotherapy is advisable and vice versa. Pharmacotherapy may be especially useful when comorbid disorders are present, which impact the patient's ability to utilize CBT. So now let's summarize case 1. The essential feature of generalized anxiety disorder is excessive anxiety and worry about a number of events or activities and lasting 6 months. The prevalence of generalized anxiety disorder is 1% in adolescents, 3% in adults, and 6% across a lifetime. Risk factors for GAD include European descent, being female, as they are affected at a rate of 2 to 1 compared to males, behavioral inhibition, neuroticism, harm avoidance, being overly conforming in childhood, perfectionistic, unsure of self, reassurance seeking, exposure to adverse childhood events, and parental overprotection. The differential diagnosis for generalized anxiety disorder includes anxiety disorder due to another medical condition, substance or medication-induced anxiety disorder, OCD, PTSD, panic disorder, social anxiety disorder, and normal reactionary anxiety. The treatment for generalized anxiety disorder includes duloxetine, agomelatine, venlafaxine, escitalopram, sertraline, paroxetine, and pregabalin. An additional first-line treatment for GAD is CBT. Routine combination of CBT and pharmacotherapy is not recommended.
Now on to case 2. Anne is a 48-year-old orofacial surgeon transferred to your office after her longtime psychiatrist relocated to another province. Her history is significant for obsessive-compulsive disorder and comorbid obsessive-compulsive personality traits, diagnosed when she was 21 years old. At that time, clomipramine and CBT were effective in reducing obsessive and intrusive homicidal thoughts about killing strangers. Once these distressing symptoms remitted, pharmacotherapy was discontinued. Obsessive-compulsive traits have persisted, and indeed, Anne has come to see them as an asset in her professional life. Most notably, she is a self-described perfectionist and prefers that her workplace be kept effing spotless. During your appointment today, Anne breaks down after sharing that her husband of 20 years passed away in a helicopter crash 2 months ago. Since this tragedy, she has experienced recurrent, intrusive, dystonic thoughts of murdering her patients during procedures. These thoughts have been so intense that she has taken a leave of absence due to the fear that she will not be able to prevent herself from murdering a patient. What is the most likely diagnosis in this case? This is obsessive compulsive disorder, which, as the name implies, is characterized by the presence of obsessions and/or compulsions. Obsessions are defined as repetitive and persistent thoughts, images, or urges which are not pleasurable and experienced as intrusive, unwanted, and involuntary, leading to marked distress and anxiety. And compulsions are defined as repetitive behaviors or mental acts which again are not pleasurable, and the individual feels driven to perform in response to obsessions or rules which must be applied rigidly. Generally speaking, there are 4 common types of obsessions: those related to cleaning, those related to harm, those related to symmetry, and those related to taboo thoughts. These can be remembered with the mnemonic CHEST.
Now that we've reviewed the diagnosis of OCD, let's discuss its epidemiology. Can someone tell me how prevalent OCD is? And what are the risk factors for OCD? So here we see that the 12-month prevalence of OCD is 1%, with a lifetime prevalence between 1 to 2%. In children, OCD is more common in males. In fact, 25% of OCD cases occur in individuals under the age of 10. In contrast with kids, the number of females exceeds the number of males with OCD in adulthood. The median age of onset is 20. Genetic and physiological risk factors include having a first-degree relative with OCD, especially if their relative had OCD in childhood. And imaging studies have demonstrated anatomical differences in the orbitofrontal cortex, anterior cingulate cortex, and striatum. These can be remembered with the mnemonic OSA. Temperamental risk factors include externalizing symptoms, higher negative emotionality, and behavioral inhibition in childhood. Environmental factors include exposure to adverse childhood events, exposure to stressful or traumatic events, and following infection, such as in pandas. So now we'll talk about the differential diagnosis of OCD. The differential diagnosis for OCD has at least 8 conditions. What are some items you might include on your differential diagnosis for OCD? So these are the 8 conditions included on the differential diagnosis of OCD. So OCD is not an anxiety disorder per se. Instead, it's included in its own chapter in the DSM titled Obsessive Compulsive and Related Disorders. To differentiate it from anxiety disorders, consider the following. Recurrent thoughts, avoidant behaviors, and repetitive requests for reassurance can also occur in anxiety disorders. However, the recurrent thoughts that are present in generalized anxiety disorder, that is, worries, are usually about real-life concerns, whereas the obsessions of OCD usually do not involve real-life concerns and can include content that is odd, irrational, or of a seemingly magical nature. Moreover, compulsions are usually present and usually linked to the obsessions. Like individuals with OCD, individuals with specific phobia can have a fear reaction to specific objects or situations. However, in specific phobia, the feared object is usually much more circumscribed, and rituals are not present. In social anxiety disorder, the feared objects or situations are limited to social interactions or performance situations, and avoidance or reassurance seeking is focused on reducing feelings of embarrassment. OCD needs to be distinguished from the rumination of major depressive disorder. in which thoughts are usually mood congruent and not necessarily experienced as intrusive or distressing. Moreover, ruminations are not linked to compulsions, as is typical in OCD. Now, we could have an entire presentation on OCD and obsessive-compulsive related disorders. In the DSM-5 TR, it has its own chapter, but for whatever reason, there are no other seminars based on this topic. So here, please bear with me as we discuss this differential diagnosis, fully acknowledging that your experience in this area may be limited. In body dysmorphic disorder, the obsessions and compulsions are limited to concerns about physical appearance, and in trichotillomania, also called hair-pulling disorder, the compulsive behavior is limited to hair pulling in the absence of obsessions. Hoarding disorder symptoms focus exclusively on the persistent difficulty discarding or parting with possessions, marked distress associated with discarding items, and excessive accumulation of objects. However, if an individual has obsessions that are typical of OCD, for example, concerns about incompleteness or harm, and these obsessions lead to compulsive accumulation, for example, acquiring all objects in a set to attain a sense of completeness, or not discarding old newspapers because they may contain information that could prevent harm, a diagnosis of OCD should be given instead. OCD can be distinguished from anorexia nervosa in that in OCD, the obsessions and compulsions are not limited to concerns about weight and food. A tic is a sudden, rapid, recurrent, non-rhythmic motor movement or vocalization. Examples include eye blinking and throat clearing. A stereotype movement is a repetitive, seemingly driven, non-functional motor behavior. Examples include head banging, body rocking, self-biting, or jiggling your leg up and down. Tics and stereotype movements are typically less complex than compulsions and are not aimed at neutralizing obsessions. However, distinguishing between complex tics and compulsions can be difficult. Whereas compulsions are usually preceded by obsessions, tics are often preceded by premonitory sensory urges. Some individuals have symptoms of both OCD and a tic disorder, in which case both diagnoses may be warranted. Some individuals with OCD have poor insight or even delusional OCD beliefs. However, they have obsessions and compulsions, distinguishing their condition from delusional disorder, and do not have other features of schizophrenia or schizoaffective disorder, such as hallucinations or disorganized speech. For individuals whose OCD symptoms warrant the with absent insight delusional belief specifier, these symptoms should not be diagnosed as a psychotic disorder. Certain behaviors are sometimes described as compulsive, including sexual behavior in the case of paraphilias, gambling in the case of gambling disorder, and substance use, such as alcohol use disorder. However, these behaviors differ from the compulsions of OCD in that the person usually derives pleasure from the activity and may wish to resist it only because of its deleterious consequences. Although obsessive-compulsive personality disorder and OCD have similar names, the clinical manifestations of these disorders are quite different. Obsessive-compulsive personality disorder is not characterized by intrusive thoughts, images, or urges, or by repetitive behaviors that are performed in response to these intrusive symptoms. Instead, it involves an enduring and pervasive maladaptive pattern of excessive perfectionism and rigid control. If an individual manifests symptoms of both OCD and OCPD, both diagnoses can be given. Now we've reviewed the differential diagnosis of OCD, and we're pretty clear that Anne is suffering from the condition. How would you like to proceed with treatment? Said another way, what would your management plan look like? For first-line pharmacotherapy for OCD, there are 5 medications which are commonly used. These include escitalopram, which is an SSRI, fluoxetine, which is an SSRI, fluvoxamine, which is an SSRI, sertraline, which is an SSRI, and paroxetine, which is an SSRI. The utility of these medications has led to the theory that serotonin is dysregulated in OCD. This may explain why clomipramine was traditionally used for treatment of OCD prior to the advent of SSRIs, because clomipramine is the most serotonergic tricyclic antidepressant. The mnemonic to remember the first-line pharmacotherapy for OCD is effing spotless, with EFF and SP standing for the SSRIs used in this disorder. Like GAD, CBT is recommended as first-line psychotherapy for OCD. In particular, one type of CBT is recommended. It's called exposure and response prevention, or ERP. Let me explain how it works with a brief example. Let's say your patient presents with obsessive thoughts related to germs or contamination, which causes them extreme anxiety and prevents them from interacting with other people, leading to social isolation. The best next step would be to expose them to a situation in which the obsessive thought is invoked and the compulsive behavior in this situation, something like hand washing, is prevented. With repeated exposures, the strength of the obsessive thought and its related compulsion are reduced. CBT can be effectively delivered in both individual and group settings, as well as via self-exposure, self-help books, telephone, and internet-based programs. The benefits of CBT for OCD are maintained over 1 to 5 years of follow-up. The combination of psychotherapy and pharmacotherapy appears to be superior to pharmacotherapy alone, but not to CBT alone. And data suggests that adding CBT to pharmacological treatment may yield a better long-term outcome. So this is the summary for OCD. The essential feature of OCD is the presence of obsessions, compulsions, or both. It has a 12-month prevalence of 1% and a lifetime prevalence of 1 to 2%. Risk factors for this condition include having a first-degree relative with OCD, particularly if they had OCD in childhood, anatomical differences in the orbitofrontal cortex, the anterior cingulate, and the striatum, the presence of externalizing symptoms, negative emotionality, behavioral inhibition in childhood, exposure to adverse childhood events, exposure to stressful or traumatic events, and following infection. The differential diagnosis for OCD includes anxiety disorders, major depressive disorders, other OCRD, tics, stereotypies, psychotic disorders, and other compulsive-like behaviors, as well as OCPD. Treatment for OCD includes first-line pharmacotherapy in the form of escitalopram, fluoxetine, fluvoxamine, sertraline, and paroxetine, as well as CBT, in particular ERP. Now on to case 3. You're a PGY1 working in the emergency department who's been asked to see Victoria, a 23-year-old college student with the chief concern of chest pain. She's a normal BMI and no personal or family history of risk factors for cardiac disease. Victoria tells you that she was participating in an escape room when out of nowhere she felt a surge of anxiety that was accompanied by chest pain, sweating, nausea, and an inexplicable fear of dying. Although she now reports feeling fine, these symptoms caused her friends to panic and demand that she go to the emergency department to get checked out. She expresses fear about having another episode, as it was both scary and embarrassing. What if it happens at school? After completing an admirable cardiorespiratory exam and ruling out nefarious causes of chest pain, you wait patiently for your attending to review. To assist with recall, you clumsily type, "Victoria, escape room, caused friends to panic." What do you think is the most likely diagnosis in this case? This is the diagnosis of panic disorder, which is characterized by recurrent, unexpected panic attacks. A panic attack requires 4 of the following 13 symptoms. Remembered with the mnemonic, students fear the 3 C's. This stands for sweating, trembling, unsteadiness, dissociation, excessive heart rate, nausea, tingling, shortness of breath, fear of death, fear of going crazy, chest pain, chills or hot flashes, and choking. Another mnemonic, which I find useful for remembering the symptoms of panic attacks, is just to think about the organs that are impacted. so symptoms affecting the head or brain, those affecting the heart, and those affecting the lungs. What all of these symptoms seem to have in common is their basis in increased SNS output. Now that we've reviewed the diagnosis of panic disorder, let's discuss its epidemiology. Can someone tell me how prevalent panic disorder is? And what are the risk factors for panic disorder? Now, one thing we haven't talked about so far is that panic attacks can occur outside of panic disorder. How likely do you think it is that someone will have a panic attack in their lifetime? The 12-month prevalence of panic disorder is between 2 to 3%, and lifetime prevalence of panic disorder is 5%. But the chance of having a panic attack over the course of your life is 30%, meaning that essentially 1/3 of people will experience a panic attack at some point in their life. Females are twice as likely to experience panic disorder compared to males, and the median age of onset is between 20 to 24. Genetic and physiological risk factors for panic disorder include inheritance and association with anxiety, depressive, and bipolar disorders, as well as respiratory problems. Temperamental factors include neuroticism, anxiety sensitivity, and separation anxiety in childhood. Environmental factors include exposure to sexual and physical abuse in childhood, smoking cigarettes, and the presence of interpersonal stress. There aren't as many conditions to include in the differential diagnosis of panic disorder compared to some of the other things we've talked about so far. What are some of the items you might include in the differential diagnosis of panic disorder? So this is the differential diagnosis for panic disorder included in the DSM-5. Included in the DSM-5 differential diagnosis for panic disorder is limited symptom panic attacks, in which there are less than 4 of 13 students fear the 3 C's criteria. Panic disorder should not be diagnosed if full symptom and unexpected panic attacks have never been experienced. In the case of only limited symptom unexpected panic attacks, an other specified anxiety disorder or unspecified anxiety disorder diagnosis should be considered. We've already reviewed anxiety disorder due to another medical condition, so we won't explore it further here. Similarly, let's not waste time talking about substance or medication-induced anxiety disorder. Panic attacks that occur as a symptom of another anxiety disorder are expected. That is, they are triggered by social situations in social anxiety disorder, by phobic objects or situations in specific phobia or agoraphobia, by worry and generalized anxiety disorder, by separation from home or attachment figures in separation anxiety disorder, and thus would not meet criteria for panic disorder. Now that we've identified the diagnosis, how should we go about managing this condition? There are 7 medications recommended as first-line pharmacotherapy for panic disorder. They are venlafaxine, which is an SNRI, escitalopram, which is an SSRI, sertraline, which is an SSRI, citalopram, which is an SSRI, fluoxetine, which is an SSRI, fluvoxamine, which is an SSRI, paroxetine in its continuous release form, which is an SSRI, and the mnemonic to remember these medications is VESC-F2P. Data support pharmacotherapy alone, CBT alone, and CBT combined with pharmacotherapy as initial treatments for panic disorder. CBT alone may be insufficient in patients with comorbid, moderate to severe major depression, or in those with severe, frequent panic attacks or rapid worsening of agoraphobia and/or suicidal ideation, as well as in situations where one might consider initial rescue treatment with a benzodiazepine to minimize or stop the panic attacks while waiting 4 to 12 weeks for the first-line pharmacotherapy to become effective. Also, there are patients who are not motivated to participate in CBT, preferring medication as initial treatment, or they may be too fearful to engage in any kind of exposure before being treated with first-line pharmacotherapy. For panic symptoms, CBT strategies should include exposure, and combined strategies should be considered for patients with agoraphobia. CBT can be effectively delivered in both individual and group settings, as well as via self-help books, virtual reality, and internet-based programs. The benefits of CBT are maintained during follow-up. Another useful therapy is somatic experiencing therapy, in which individuals recreate the symptoms that occur in panic attacks. An example of this would be asking your patient to do 20 jumping jacks in your office to simulate the symptoms. By exposing them to this physical experience, you are correcting their association between panic attacks and a deleterious consequence. This is a summary of panic disorder. The essential feature is recurrent, unexpected panic attacks. It has a 12-month prevalence of 2 to 3%, a lifetime prevalence of 5%, and outside of disorder, panic attacks will occur in up to 30% of people across a lifetime. Risk factors for panic disorder include some genetic influence, parents with anxiety, depressive, and bipolar disorders, respiratory problems, neuroticism, anxiety sensitivity, separation anxiety in childhood, childhood abuse, smoking, and interpersonal stress. The differential diagnosis for panic disorder includes limited symptom panic attacks, anxiety disorder due to another medical condition or due to a substance or medication, other disorders with panic attacks as a feature, and treatment for panic disorder includes venlafaxine, escitalopram, sertraline, citalopram, fluoxetine, fluvoxamine, paroxetine and its continuous release form, and CBT, as well as somatic experiencing therapy. Now on to case 4. You're a primary care physician about to see Mike, a 58-year-old officer of the Saskatoon Police Service for the chief concern of insomnia. You've been working with him for the past 24 years, although you've not seen him in clinic for the past 8 months. At your last meeting, he was in peak physical and emotional health, with the exception of seasonal allergies. He's not on any prescription medications. You find Mike to be a shell of his former self. He'd slouched over on the examination table, unshaven and wearing a wrinkled police uniform. There was an unlit cigarette butt hanging from his mouth and an extra-large Tim Hortons coffee in his hand. From the dark circles around his eyes, you can tell he has been sleeping poorly. You sensibly engage him in conversation and learn that he responded to a call about a suspicious man entering a local residence through a basement window 4 months ago. Whilst investigating the scene, Mike entered the basement and was surprised to find the suspect violent. The man charged him from across the room with an edged weapon. Instinctively, Mike drew and discharged his firearm. The man was killed instantly. In the months since, Mike has experienced recurrent nightmares and intrusive daytime symptoms related to the event. He has become despondent and depressed and unable to focus on his work. He has been unable to drive down the street where the event took place and has forgotten to equip his firearm on a number of occasions since that time. Although well known as a man with a gentle demeanor, he shared that lately he has been snapping at his wife and kids with little provocation. What is the most likely diagnosis in this case? This is a case of post-traumatic stress disorder, PTSD. The essential feature of this disorder is that symptoms of PTSD develop after a traumatic event. Trauma has become a bit of a loaded term. According to the DSM, this table encapsulates all of the events which can result in PTSD and are classified as traumatic events. It's important to differentiate between trauma and PTSD and trauma in the psychodynamic sense. In the psychodynamic sense, any event can be traumatic if it causes significant change in someone's personality or personality development, whereas in PTSD, trauma refers to these traumatic experiences only. Now that we've reviewed the diagnosis of PTSD, let's discuss its epidemiology. Can someone tell me how prevalent PTSD is? And what are the risk factors for PTSD? The 12-month prevalence of PTSD is 3.5%, and the lifetime prevalence is 9%. Females are affected twice as frequently as males, and a lot of this difference is attributable to sexual assault. The median age of onset is in the 20s. Risk factors for this condition include female sex, minority status, younger age, and lower intelligence, having a fatalistic or self-blaming coping strategy, and those who make negative appraisals of themselves. Environmental risk factors include vocations where traumatic exposures are common, being involved in combat, captivity, internment, or genocide, lower socioeconomic status, and exposure to adverse childhood events. The differential diagnosis for PTSD is quite long and includes 11 conditions. What are some of the items you might include on your differential for a patient presenting with PTSD? So this is the differential diagnosis for post-traumatic stress disorder. In adjustment disorders, the stressor can be of any severity or type rather than a stressor involving exposure to actual or threatened death, serious injury, or sexual violence as required by PTSD Criterion A. The diagnosis of an adjustment disorder is used when the response to a stressor that meets PTSD Criterion A does not meet all other PTSD criteria, or criteria for another mental disorder. An adjustment disorder is also diagnosed when the symptom pattern of PTSD occurs in response to a stressor that does not meet PTSD Criterion A, such as a spouse leaving or being fired from your job. Not all psychopathology that occurs in individuals exposed to an extreme stressor should necessarily be attributed to PTSD. The PTSD diagnosis requires that trauma exposure precede the onset or exacerbation of pertinent symptoms. If the symptom response pattern to the extreme stressor meets criteria for another mental disorder, these diagnoses should be given instead of, or in addition to, PTSD. Other diagnoses and conditions are excluded if they are better explained by PTSD. For example, symptoms of panic disorder that occur only after exposure to traumatic reminders. If severe, symptom response patterns to the extreme stressor that meet criteria for another mental disorder may warrant a separate diagnosis, such as dissociative amnesia, in addition to PTSD. Acute stress disorder is distinguished from PTSD because the symptom pattern in acute stress disorder is restricted to a duration of 3 days to 1 month following exposure to the traumatic event. In OCD, there are recurrent intrusive thoughts, but these meet the definition of an obsession. In addition, the intrusive thoughts are not related to an experienced traumatic event. Compulsions are usually present, and other symptoms of PTSD or acute stress disorder are typically absent. Neither the arousal and dissociative symptoms of panic disorder, nor the avoidance, irritability, and anxiety of generalized anxiety disorder are associated with a specific traumatic event. The symptoms of separation anxiety disorder are clearly related to separation from home or family rather than to a traumatic event. Major depression may or may not be preceded by a traumatic event and should be diagnosed if full criteria have been met. Specifically, major depressive disorder does not include any PTSD Criterion B or C symptoms, nor does it include a number of symptoms from PTSD Criterion D or E. However, if full criteria for PTSD are also met, both diagnoses may be given. Both ADHD and PTSD may involve problems in attention, concentration, and learning. In contrast to ADHD, where the problem in attention, concentration, and learning must have their onset prior to age 12, in PTSD the symptoms have their onset following exposure to a Criterion A traumatic event. In PTSD, disruption in the individual's attention and concentration can be attributable to alertness to danger and exaggerated startle response to reminders of the trauma. Interpersonal difficulties that had their onset or were greatly exacerbated after exposure to a traumatic event may be an indication of PTSD rather than a personality disorder in which such difficulties would be expected independently of any traumatic exposure. Dissociative amnesia, dissociative identity disorder, and depersonalization derealization disorder may or may not be preceded by exposure to a traumatic event or may not have a co-occurring PTSD symptom. When full PTSD criteria are also met, the PTSD with dissociative symptoms subtype should be considered. New onset of somatic symptoms within the context of post-traumatic distress might be an indication of PTSD rather than functional neurological symptom disorder. It's important to examine the timeline. Flashbacks in PTSD must be distinguished from illusions, hallucinations, and other perceptual disturbances that may occur in schizophrenia, brief psychotic disorder, and other psychotic disorders. Depressive and bipolar disorders with psychotic features, delirium, substance or medication-induced disorders, and psychotic disorders due to another medical condition. PTSD flashbacks are distinguished from these other perceptual disturbances by being directly related to the traumatic experience and by occurring in the absence of other psychotic or substance-induced features. Some types of traumatic events increase the risk of both PTSD and traumatic brain injury because they can produce head injuries. This includes things like military combat, bomb blasts, child physical abuse, intimate partner violence, violent crime, motor vehicle, or other accidents. In such cases, individuals presenting with PTSD may also have TBI, and those presenting with TBI may also have PTSD. Individuals with PTSD who also have TBI may have persistent post-concussive symptoms, such as headaches, dizziness, sensitivity to light or sound, irritability, and concentration deficits. However, such symptoms may also occur in non-brain injured populations, including individuals with PTSD. Because symptoms of PTSD and TBI-related neurocognitive symptoms can overlap, a differential diagnosis between PTSD and neurocognitive disorder symptoms attributable to TBI may be possible based on the presence of symptoms that are distinctive to each presentation. Whereas re-experiencing and avoidance are characteristic of PTSD and not the effects of TBI, persistent disorientation and confusion are more specific to TBI, the neurocognitive effects, than to PTSD. TBI-related memory problems concerning the traumatic event are typically attributable to injury-related inability to encode the information, whereas PTSD-related memory problems typically reflect dissociative amnesia. Sleep difficulties are common to both disorders. Okay, now that we are a little more certain about the diagnosis in this case, how should we go about treating it? There are four main pharmacotherapies used for treatment of PTSD. These are paroxetine, which is an SSRI, fluoxetine, which is an SSRI, sertraline, which is an SSRI, and venlafaxine, which is an SNRI. The mnemonic for these medications is, police find suspect violent. What medication would you use to treat nightmares in PTSD? The answer is prazosin, an alpha-1 antagonist. Evidence does not support widespread use of early intervention with psychological strategies for the prevention of PTSD. Debriefing of all trauma victims is not recommended. Rather, screening and treating appropriate individuals is preferred. CBT is an effective first-line option for treatment of PTSD, and benefits are maintained during long-term follow-up, 1 to 10 years after treatment. Research evaluating combined psychological and pharmacological treatments in PTSD is limited, and this requires further study. Trauma-focused CBT is a therapy that directly addresses the impact of traumatic events. There are three main versions of trauma-focused CBT that have been proven in scientific studies to be effective for PTSD. The therapy can also help with depression and anxiety that goes along with PTSD. So this is the summary for post-traumatic stress disorder. The essential feature of PTSD is characteristic symptoms following a traumatic event. The 12-month prevalence of PTSD is 3.5%, whereas the lifetime prevalence is 9%. Risk factors for PTSD include female sex, minority status, younger age, lower intelligence, fatalistic or self-blaming coping strategies, negative appraisals, location, sexual assault, military combat or captivity, internment or genocide, lower socioeconomic status, and adverse childhood events. The differential diagnosis for PTSD includes adjustment disorders, other post-traumatic disorders, acute stress disorder, anxiety disorders and OCD, major depressive disorder, ADHD, personality disorders, dissociative disorders, focal neurological symptom disorder, psychotic disorders, and TBI. Pharmacotherapies for PTSD include paroxetine, fluoxetine, sertraline, and venlafaxine. In the case of nightmares, prazosin may be indicated, and CBT and other therapies can be useful. Now on to Case 5. Vesper is a 13-year-old female referred to your office for assessment of extreme shyness. She is reticent and difficult to engage in history-taking. Thankfully, her foster mother has attended with her and is able to provide collateral history. Vesper has been in foster care for 6 years. Both of her biological parents suffer from substance use disorders and would often leave her alone at home under the care of her grandmother, who was extremely controlling and would often use humiliation as punishment. You were told she has always been shy, but after moving to a new school 6 months ago, she has expressed concerns about being humiliated or embarrassed in front of others. Vesper fears pure child reactions, although this has not happened. As a result of these fears, she has been missing school. She blushes as her caregiver shares these details with you. What is the most likely diagnosis in this case? This is social anxiety disorder, the essential feature of which is marked fear or anxiety of social situations where the individual may be scrutinized. And for kids, it must be related to experiences with peers. Now that we've reviewed the diagnosis of social anxiety disorder, let's discuss its epidemiology. Can someone tell me how prevalent social anxiety disorder is? What are the risk factors for social anxiety disorder? The 12-month prevalence of social anxiety disorder is 7%, and the lifetime prevalence is 12%, with a median age of onset of 13. Risk factors for social anxiety disorder include first-degree relative with social anxiety disorder, female sex, behavioral inhibition, fear of negative evaluation, inadequately assertive or excessively submissive personality traits, or social inhibition and shyness in childhood. Environmental risk factors include childhood maltreatment, adverse childhood events, exposure to stressful or humiliating experiences, or assuming new roles, such as transitioning from elementary school to high school or from university into medical school. There are 15 items included in the differential diagnosis for social anxiety disorder. Can you name some of them? This is the differential diagnosis for social anxiety disorder. Shyness, also known as social reticence, is a common personality trait and is not by itself pathological. In some societies, shyness is even evaluated positively. However, when there is a significant adverse impact on social, occupational, and other important areas of functioning, a diagnosis of social anxiety disorder should be considered. And when full diagnostic criteria for social anxiety disorder are met, the disorder should be diagnosed. Only a minority, that is 12%, of self-identified shy individuals in the United States have symptoms that meet diagnostic criteria for social anxiety disorder. Individuals with agoraphobia may fear and avoid social situations, such as going to a movie, because escape might be difficult or help might not be available in the event of incapacitation or panic-like symptoms, whereas individuals with social anxiety disorder are most fearful of scrutiny by others. Moreover, individuals with social anxiety disorder are likely to be calm when left entirely alone, which is often not the case in agoraphobia. Individuals with social anxiety disorder may have panic attacks, but the panic attacks are always cued by social situations and do not occur out of the blue. Additionally, individuals with social anxiety disorder are more likely to be distressed by the fear of negative evaluation stemming from a panic attack than by the panic attacks themselves. Social worries are common in generalized anxiety disorder, but the focus is more on the nature of ongoing relationships rather than on fear of negative evaluation. Individuals with generalized anxiety disorder, particularly children, may have excessive worries about the quality of their social performance, but these worries also pertain to non-social performance and when the individual is not being evaluated by others. In social anxiety disorder, the worries focus on social performance and others' evaluation. Individuals with separation anxiety disorder may avoid social settings, including school refusal, because of concerns about being separated from attachment figures, or in children, about requiring the presence of a parent when it is not developmentally appropriate. Individuals with separation anxiety disorder are usually comfortable in social situations when their attachment figure is present or when they are at home, whereas those with social anxiety disorder may be uncomfortable when social situations occur at home or in the presence of attachment figures. Individuals with specific phobias may fear embarrassment or humiliation, such as embarrassment about fainting when they are having their blood drawn, but they do not generally fear negative evaluation in other social situations. Individuals with selective mutism may fail to speak because of fear of negative evaluation, but they do not fear negative evaluation in social situations where no speaking is required, such as in nonverbal play. Individuals with major depressive disorder may be concerned about being negatively evaluated by others because they feel they are bad or not worthy of being liked. In contrast, individuals with social anxiety disorder are worried about being negatively evaluated because of certain social behaviors or physical symptoms. Individuals with body dysmorphic disorder are preoccupied with one or more perceived defects or flaws in their physical appearance that are not observable or appear slight to others. This preoccupation often causes social anxiety and avoidance. If their social fears and avoidance are caused only by their beliefs about their appearance, a separate diagnosis of social anxiety disorder is not warranted. Individuals with delusional disorder may have non-bizarre delusions and/or hallucinations related to the delusional theme that focuses on being rejected by or offending others. Although the extent of insight into beliefs about social situations may vary, many individuals with social anxiety disorder have good insight that their beliefs are out of proportion to the actual threat posed by the social situation. Social anxiety and social communication deficits are hallmarks of autism spectrum disorder. Individuals with social anxiety disorder typically have adequate age-appropriate social relationships and social communication capacity, although they may appear to have impairment in these areas when first interacting with unfamiliar peers or adults. Given its frequent onset in childhood and its persistence into and throughout adulthood, social anxiety disorder may resemble a personality disorder. The most apparent overlap is with avoidant personality disorder. Individuals with avoidant personality disorder have a broader avoidance pattern and higher rates of impairment than those individuals with social anxiety disorder. Moreover, individuals with avoidant personality disorder have a strong and pervasively negative self-concept, a view of rejection as equating to a global evaluation of the self as being of little worth, and a sense of not fitting in socially that dates from early childhood. Nonetheless, social anxiety disorder is typically more comorbid with avoidant personality disorder than with any other personality disorder, and avoidant personality disorder is more comorbid with social anxiety disorder than with any other anxiety disorder. Social fears and discomfort can occur as a part of schizophrenia, but other evidence for psychotic symptoms is usually present. In individuals with an eating disorder, it is important to determine that fear of negative evaluation about eating disorder symptoms or behaviors, that is, purging and vomiting, is not the sole source of social anxiety before applying a diagnosis of social anxiety disorder. Similarly, obsessive-compulsive disorder may be associated with social anxiety, but the additional diagnosis of social anxiety disorder is used only when the social fears and avoidance are independent of the foci of the obsessions and compulsions. Medical conditions may produce symptoms that may be embarrassing, for example, trembling in Parkinson's disease. When the fear of negative evaluation due to other medical conditions is judged to be excessive, a diagnosis of social anxiety disorder should be considered. Refusal to speak because of opposition to authority figures should be differentiated from failure to speak because of fear of negative evaluation in oppositional defiant disorder. How would you approach treatment in this case of social anxiety disorder? There are 6 medications used as first-line treatments for social anxiety disorder. These are venlafaxine, which is an SNRI, escitalopram, which is an SSRI, sertraline, which is an SSRI, pregabalin, which binds the alpha-2 delta subunit of the voltage-gated calcium channel, fluvoxamine and its continuous release form, which is an SSRI, paroxetine, continuous release, which is an SSRI. The mnemonic for these medications is VESP-F/PCR. Psychotherapy is also indicated. CBT and exposure therapy alone are effective first-line options for treatment of social anxiety disorder, although limited data suggests that CBT may be more effective in maintaining benefits during follow-up compared to pharmacotherapy. Virtual reality exposure and internet-based programs have also demonstrated efficacy. The benefits of CBT are maintained 1 to 5 years after follow-up. CBT and pharmacotherapy appear to have similar efficacy for acute treatment of social anxiety disorder, but after treatment discontinuation, gains achieved with CBT appear to persist longer than those achieved with pharmacotherapy. In most studies, adding pharmacotherapy has not been shown to increase the benefits of CBT. This is a summary of social anxiety disorder. Here the essential feature is marked fear or anxiety of social situations where the individual may be scrutinized. The 12-month prevalence is 7%, and the lifetime prevalence is 12%. Risk factors for this disorder include a first-degree relative with social anxiety disorder, female sex, behavioral inhibition, fear of negative evaluation, inadequately assertive or excessively submissive personality traits, social inhibition and shyness, childhood maltreatment, adverse childhood events, exposure to stressful or humiliating experiences, and role transition. The differential diagnosis for social anxiety disorder includes normative shyness, agoraphobia, panic disorder, generalized anxiety disorder, separation anxiety disorder, specific phobia, selective mutism, major depressive disorder, body dysmorphic disorder, delusional disorder, autism spectrum disorder, personality disorders, other mental disorders, and other medical conditions, as well as oppositional defiant disorder. Pharmacological treatments for social anxiety disorder include venlafaxine, escitalopram, sertraline, pregabalin, fluvoxamine its continuous release form, and paroxetine continuous release. Psychotherapy is also indicated in the form of CBT for the treatment of social anxiety disorder. Now to summarize this presentation, the essential feature of generalized anxiety disorder is excessive anxiety and worry about a number of events or activities going on for at least 6 months. The essential feature of obsessive compulsive disorder is obsessions, compulsions, or both. The essential feature of panic disorder is recurrent, unexpected panic attacks. The essential feature of PTSD is characteristic symptoms following a traumatic event. And the essential feature of social anxiety disorder is marked fear or anxiety of social situations where one might be scrutinized. These are the objectives again for this presentation. I hope that now you are able to recall the essential features of generalized anxiety disorder, OCD, panic disorder, PTSD, and social anxiety disorder. I hope that you're able to comment on the epidemiology and risk factors for each of these disorders. I hope you're able to create a 3 to 4 item differential diagnosis for each of these disorders. I hope that you're able to name some common medications used to treat these disorders, and name some common therapies used for treatment of these conditions as well. These are the references used for this presentation. Thank you for your attention and participation. If there are any questions or comments, I'd be happy to answer them now. Thank you.